Good morning, everyone. It's my great pleasure to start the Hepato Pernambuco webinar. And this conference is completely different from the all previous edition from Hepato Pernambuco. Do you know that due to the coronavirus COVID-19 pandemic, the Congress this year, only its 24th edition, Hepato Pernambuco, will be totally different and online, like liver talks. All liver talks will be held by international speakers, and the debate and moderation by national speakers, experts. All the program activities will occur weekly, mostly by national, with a total about 1 hour 15 minutes between July and August through Zoom Pro platform, and the capacity of the limit is over 100 views. Access will be completely free and unrestrictedly new participation. I have a great pleasure as well. First of all, I'd like to introduce myself. I'm Leila Beltrão Pereira, full professor of gastroenterology from Faculdade de Ciências Médicas da University of Pernambuco. And another pleasure is share with Professor Carlos Brandão, President of the Brazilian Hepatology Society. Also, all the debaters is Professor Alberto Farias and Dr. Mário Pessoa, both from the FM USP, Faculdade de Medicina da University of São Paulo. From the beginning, I'd like to say that I expect that many people could be participating in this conference. There is a chat that you could access and ask many questions. And myself and will be asking Professor Alberto and Mário Pessoa to ask Professor Steve and start our debate. Also, Steve, it's my great pleasure to have you here with the co-chair in the Faculdade de Medicina da Universidade de São Paulo, University of São Paulo. That's in this routine meeting every Wednesday, 11 o'clock. And it's very nice to have you here, participate together with these two meetings that we join to the conference, the initial conference, the open ceremony in the Hepato Pernambuco 2020. Now, I'd like to introduce some the panel. Sorry, Stevie. As I asked you to, I'd like to talk in Portuguese now because I have to introduce some our societies and all the universities to support us in our meeting. After this, I come back to speak in English and I pass the conference to you starting, and your talk is around 30 minutes, and after that you have a case report to be discussed together.
Bom, meu nome é Carlos Eduardo Brandão, eu sou o presidente da Sociedade Brasileira de Hepatologia e, em meu nome, em nome de toda a diretoria da SBH, gostaria de agradecer a professora Leila Beltrão pela iniciativa de mais uma jornada do Hepato Pernambuco, pela primeira vez de modo virtual, de modo digital, devido a esses últimos 100 dias de pandemia do coronavírus que nós estamos enfrentando. Além dessa pandemia sanitária, que talvez tenha sido a mais importante desses últimos 100 anos, estamos ainda vivendo uma outra pandemia, que é uma pandemia socioeconômica, uma pandemia política, cultural, e que nos fez nos afastarmos de todos nós, colegas, ao longo desses últimos 100 dias, praticamente cerca de 10 eventos nacionais deixaram de ser realizados de forma presencial, nas jornadas no Rio, em São Paulo, Hepatologia do Milênio, Latino-Americano de Fígado, Congresso Europeu de Fígado, enfim. E já sabemos também de eventos do segundo semestre, como o Americano de Fígado, o SBAD, que é a Sociedade Brasileira de Gastroenterologia, ou seja, esse é um ano em que a maioria dos nossos eventos que deveriam ser presenciais serão eminentemente virtuais. Então, eu queria parabenizar a Leila pela iniciativa de manter a tradição do evento do Hepato Pernambuco, mesmo que de modo digital. Nós tivemos, há mais ou menos um mês atrás, a jornada da Semana do Fígado do Rio de Janeiro, uma reunião também virtual. Temos tido a oportunidade de ver jornadas semanais do grupo do professor Paraná, do professor Flair, tentando manter as atividades de cada um dos seus serviços. E a Sociedade Brasileira de Hepatologia também, de alguma maneira, tem mantido as suas atividades através de recomendações, notas técnicas, principalmente sobre como manejar as manifestações hepáticas durante a infecção pelo coronavírus. Mais recentemente, fizemos uma recomendação que foi capitaneada pelo grupo da doutora Cássia Leal, doutora Aline Chagas, professor Flair Carrilho, o grupo da doutora Gabriela Coral, enfim, todos os colegas do grupo de referência e de interesse em carcinoma hepatocelular. Fizemos também uma recomendação sobre o manejo do carcinoma hepatocelular na era da pandemia do Covid. E a doutora Rita Silva, de São José do Rio Preto, juntamente com outros colegas do grupo de interesse de transplante, também estão redigindo uma recomendação sobre como manejar o paciente de transplante hepático na era do Covid. Nós estamos começando hoje, dia 1º de julho, o chamado Julho Amarelo. A Sociedade Brasileira de Hepatologia já se organizou no sentido de fazer, junto com o seu braço da sua fundação, que é o IBRAFIG, uma série de podcasts, de vídeos, de mensagens para a população leiga. E nós já temos 2 eventos científicos programados para o mês de julho, um que realizar-se-á no dia 16 de julho, que será um evento que vai ser o primeiro módulo de um programa de educação médica continuada online sobre hepatite B. E no dia 30 de junho, um evento também sobre manifestações hepáticas da infecção pelo Covid, aí uma jornada que vai ocupar praticamente 1h30, 2 horas sobre isso. Enfim, começamos o mês de julho, hoje com a jornada da doutora Leila, e teremos ao longo desse mês de julho 2 outros eventos científicos, um no dia 16 sobre hepatite B e outro no dia 30 sobre manifestações hepáticas da Covid. Então, um aspecto muito importante que são as manifestações, as alterações da coagulação em pacientes com doenças hepáticas crônicas, com cirrose em particular. Eu tenho um interesse particular nessa área da coagulação. Durante mais de 20 anos, trabalhei no Instituto de Hematologia do Rio de Janeiro, trabalhando muito com pacientes hemofílicos, minha tese de mestrado, doutorado e até de docência livre foi feita com pacientes com coagulopatias hereditárias, com hemofilia. Esse é um assunto que eu acho. Então, sem mais delongas, eu devolvo introduzir o nosso speaker, dizer que nós teremos também 2 debatedores, o professor Alberto Farias, professor da Faculdade de Medicina da Universidade de São Paulo, livre-docente da USP, e o professor Mário Pessoa, também, que é médico doutor do próprio Serviço de Hepatogastroenterologia do Hospital das Clínicas da Universidade de São Paulo. Então, devolvo a coordenação à doutora Leila para que ela possa fazer a apresentação do professor Stephen Caldwell, que dispensa as apresentações, mas ela fará de forma formal essa introdução. Muito obrigado.
Professor Brandão, Carlos Brandão, antes eu gostaria de fazer os meus agradecimentos, né, a todos que nos apoiaram, né, iniciando pelos apoiadores, o professor Pedro Falcão, reitor da Universidade de Pernambuco, do qual eu muito me orgulho de ser professora titular, a professora Maria Socorro Cavalcante, a vice-reitora da Universidade de Pernambuco, a professora Dione Tavares Maciel, da Faculdade de Ciências Médicas, da qual eu pertenço ao quadro da Faculdade de Medicina, a professora Isabel, diretora do Hospital Universitário Oswaldo Cruz, a professora Zuma Medeiros, coordenadora do Programa de Ciências da Saúde da Faculdade de Ciências Médicas, o professor Carlos Eduardo Brandão, presidente da Sociedade Brasileira de Hepatologia, o professor Delcio Xizon, representando a sociedade como secretário-geral da Federação Brasileira de Gastroenterologia, o professor Joel Higgins Garcia, presidente da Associação Brasileira de Órgãos, o professor Clóvis Arnes, presidente da Sociedade Brasileira de Infectologia, o professor Mário Reis, presidente do projeto ECO, né, com sede na Universidade Federal de Porto Alegre, e Pedro Castor, presidente do Congresso Brasileiro de Hepatologia, de Gastroenterologia da Universidade de Pernambuco, como liga. Esses são os jovens hoje que eu muito estimulo, né? São os nossos futuros gastrohepatologistas, é assim que a gente imagina. Então, o Hepato Pernambuco, além de ser uma troca de conhecimento entre nós, mas principalmente um estímulo a essa juventude que serão os futuros gastrohepatologistas do nosso país e, quem sabe, internacionalmente reconhecidos. Gostaria também de agradecer, né, a quem realizou esse evento ao meu lado, o professor Vitorino Spinelli, o meu grande, eterno mestre, né, meu professor, e hoje vice-presidente do Instituto Fígado e Transplant de Pernambuco, no qual ele representa a nossa instituição hoje nessa cerimônia. A Laís Coutinho, presidente do NAP, o Núcleo de Apoio aos Pacientes Hepáticos. Ao professor Flair Carrilho, professor titular e chefe do Departamento de Gastroenterologia da USP, do qual os meus sinceros agradecimentos, professor Flair, por ceder esse horário, juntamente com o coordenador da reunião, Dr. Mário Pessoa, e o professor Alberto Farias, que nos deram essa oportunidade, no qual eu agradeço a todos e gostaria, antes de começarmos realmente, oficialmente, eu me sentiria muito honrada em fazer duas homenagens. Primeira homenagem, você pode colocar a foto, por favor, Adriana? Ao que eu posso dizer ao meu grande mentor, uma saudade infinita, Dr. Ricardo Coimbra de Almeida Brenan, foi a pessoa que transformou o meu sonho no nosso sonho, idealizar o Instituto do Fígado e Transplante de Pernambuco, sempre ao nosso lado, um número de empresários, e infelizmente ele foi uma vítima do Covid-19, nos deixando para o espaço celestial em abril deste ano. Essa é a homenagem que eu faço, não só através do Instituto do Fígado, mas o Dr. Ricardo Brenan sempre participou. Muitos de vocês devem estar lembrados ele nas conferências que a gente fazia. Então, é uma memória viva do nosso congresso. Eu não poderia deixar de prestar homenagem a esse grande imortal Ricardo Brenan. E para dar início, né, eu acho que Pernambuco ele representa algo não só no que se diz na parte intelectual, né, na parte científica, mas nós temos alguns marcos importantes no nosso estado, né, e é aqui que a gente vai apresentar a vocês em apenas 2 minutos o hino de Pernambuco, Imortal, Imortal, através do grande imortal Alceu Valença.
Coração do Brasil, em teu seio corre o sangue de heróis rubro-veio, que há de sempre o valor traduzir. És a fonte da vida e da história desse povo coberto de glória, o primeiro talvez no porvir. Salve a terra dos altos fogueiros, de beleza soberba estendal, Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. Esses montes e vales e rios, proclamando o valor de teus brios, reproduzem batalhas cruéis. No presente és a guarda avançada, sentinela indormida e sagrada, que defende da paz dos lauréis. Salve a terra dos altos coqueiros, que beleza soberba espendal. Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. No futuro és a crença, a esperança desse povo que altivo descansa, como atleta depois de lutar. No passado teu nome era mito, era o sol a brilhar no infinito, era a glória na terra a brilhar. Salve a terra dos altos coqueiros, de beleza soberba estendal. Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. A república é filha de Olinda, aura estrela que fuge, não finda, de esplender com seus raios de luz. Liberdade o teu filho proclama, dos escravos o peito inflama, ante o sol dessa terra da cruz. Salve a terra dos altos coqueiros, de beleza soberba estendal. Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. Salve a terra dos altos coqueiros, de beleza soberba estendal. Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. Pernambuco imortal, imortal. Pernambuco imortal, imortal.
Bom, então vamos dar início, é assim que a gente homenageia a todos vocês. Esperamos que em 2021 nós podemos estar nos abraçando, nos cumprimentando pessoalmente, nesse ritmo de frevo, de alegria que Pernambuco sempre traz para vocês e para o Brasil. Então, eu gostaria de passar a palavra ao professor Mário Pessoa para fazer a introdução, eu juntamente com o professor Alberto Farias, para o início da palestra do professor Caldwell.
Bom dia a todos. Muito obrigado, Leila. É um prazer estar aqui nessa reunião conjunta, que hoje é a reunião também da Divisão de Gastroenterologia e Hepatologia, aqui do serviço, e nós, junto com o professor Flaí, temos feito as reuniões semanais também, pelo Google Meet, e é um prazer para nós estarmos aqui com você hoje. E Steve Caldwell é um querido amigo nosso também, já nos visitou algumas vezes e teve sempre uma parceria muito grande de trabalho, não só com a Cláudia Oliveira, em termos de NASH, com o Alberto Farias, em termos de coagulação e fígado. E eu passo, assim, o Steve é um convidado do Alberto essa semana, e eu peço ao Alberto para introduzir o Steve, para ele poder falar para a gente. Obrigado, Leila.
Bom dia a todos. Eu queria agradecer ao professor Steve Caldwell por aceitar esse convite de participar dessa reunião. Nós temos quase 1000 pessoas que nos assistem. Esse é um tema de grande relevância. Eu não vou me estender, eu queria dizer que o professor Steve Caldwell é o representante mais ilustre do Grupo Internacional de Estudos da Coagulopatia na Cirrose. É o maior expert mundial nessa área e temos certeza de que a sua apresentação, seguida pela discussão de caso clínico, será extremamente produtiva. Steve, thank you very much for accepting our invitation. It's a pleasure to have you today with us in this meeting. Thank you again.
Okay, all right. Bom dia a todos. Tudo bem? Espero que sim. I missed my pão and queijo at Guarulhos, but we'll work with this. So should I shrink my screen so I don't know what everybody can see? Okay, so everyone knows the liver sort of sits in the middle of the coagulation pathways. It makes anticoagulant factors, procoagulant factors, governs platelet homeostasis and endothelial function. And as a result, it really governs a lot to do with bleeding and clotting. So our focus today will be on bleeding and clotting in cirrhosis patients without malignancy. Malignancy and cirrhosis and portal vein thrombosis in patients without cirrhosis are entirely different topics. And I'd encourage you, if you're studying this or you're doing clinical research with it, that you separate these three out and don't mix them together, because they're very different. So I'm going to present a series of cases that I hope will illustrate key points. The first one is a 43-year-old male with newly diagnosed autoimmune hepatitis and cirrhosis by transvenous biopsy. He was 1 week into prednisone therapy with an early good response by liver enzymes. His wedge pressure was 22 millimeters mercury. His INR was 2.2, and his platelets were 41,000. He had no history of bleeding or easy bruising. He was tired, but he didn't have HE. He had only minimal ascites. And you can see, this is his scope, and you see this high-risk varix. And all of these are real cases. So he's got high-risk marks, pretty big varices. And what would you do? Would you stop here and try to so-called correct these numbers, or would you go on ahead and ban? And I'll tell you what we did. Well, first question that I think we should ask is the INR a good measure of bleeding risk in liver disease? And this is kind of old data now. Many of you have seen these studies, but these were two early studies looking at INR in patients, 5 patients here, 14 or so here. And blood was drawn at the same time and sent to different clinical laboratories. And you can see, if you're trying to get a cutoff for INR, the traditional one has been 1.5. And you can see here how many times the same specimen taken at the same moment, sent to 2 different labs, you get different results. And this is because they are using different reagents, in particular the thromboplastin that goes into the prothrombin time. Moreover, let's say you accept that number and you want to try to correct the INR. Well, this is a laboratory study done comparing cirrhosis patients to controls, and they added normal plasma at a dose equivalent to 10 ml per kilogram. So a big slug of plasma. And what did it do to the clotting parameters? Well, it improved the prothrombin time, shortened it significantly. But when you look at thrombin production, it didn't do anything. And thrombin production, that's factor 2, that's right before you convert fibrinogen to fibrin. So it really didn't have a positive effect on a key parameter of hemostasis. Even more impressive is a study from Alberto and the team there at USP, which I think was really an exciting study. This was done by giving prophylactic plasma, 10 ml per kilogram body weight, or about 4 units on average of plasma. The patient's about to undergo various procedures. And they measured thrombin generation in the patients. And not only did it not improve thrombin generation, it actually decreased thrombin generation in about 1/3 of the patients, probably due to replacing protein C. We'll circle back to protein C deficiency in cirrhosis at the end of the talk. But so not only do you have a test that's not accurate, you have an intervention that's not effective and maybe counter-effective. Moreover, it's been shown, this is an old study, very old, as you can see, 1974. But I like it because it was really a direct measurement of portal pressure in patients undergoing surgical shunts, which were popular back in the time. They infused volume into the patient and measured the portal pressure. And you can see there's a linear relationship in most of the patients. Portal pressure went up as you expanded their blood volume. So now you're adding to the whole problem with INR, the reaction actually worsens portal pressure. So in that case, we went ahead and banded at that time. We didn't have any problems. He's now undergone serial banding and has done really pretty well. He's maintained a clinical remission. Platelets are still not very good, but he has not had overt bleeding. Well, we know that we have good reason to be concerned about bleeding in these patients, especially when we're doing procedures. This is a study from Austria. I think it's one of the most convincing studies. They looked at excuse me, patients without cirrhosis and with cirrhosis in an ICU. And then they looked at no major bleeding or major bleeding. And dark gray is major bleeding. And you can see the cirrhosis patients had significantly more bleeding events than the non-cirrhosis. So we've got a reason to be concerned. And procedural bleeding was also significantly more frequent in the cirrhosis patients compared to the non-cirrhosis patients. They correlated this to what they called a DIC score, but really the two parameters that went into what they called DIC score were platelets and fibrinogen. And that has given rise really to those two parameters kind of becoming our at least for now, our benchmarks. We also have to estimate procedure-related bleeding risk. This is going to be in the eyes of the operator. So whoever's got the needle or the device in their hand, they're the ones that are so-called on the bubble. And so they have to assess the bleeding risk. In general, this is a consensus though from our 2017 meeting, and low-risk procedures were considered paracentesis, diagnostic and therapeutic endoscopy for varices. Thoracentesis is actually here. I would have voted to put it in intermediate risk, but the consensus would put it in low risk. Intermediate included PEGs, sphincterotomy. Sphincterotomy I would have put in the high risk because I think if they've got portal hypertension, that can be a real problem. But the agreement was definitely for large polypectomy or mucosal resections. And then what are the recommended interventions? Again, this is consensus, and we could argue this. We get a lot of letters in response to these papers, some critical. But based on thrombin generation, we recommend platelets over 50,000 if you've judged it to be a high-risk intervention, or fibrinogen greater than 120 to 150. Mainly based on trauma literature. And most importantly, avoid chasing the INR for all the reasons that I've just said. And with regard to platelets, we do have some data, again, data from Tripati, looking at what does a standard unit dose of platelet infusion do. He measured ROTEM before and after. And you can see the mean platelet count before was 39,000, after was 52,000, a little better than I would have guessed. And most of the clotting parameters, though, didn't change very much. Again, this is only one unit, but the maximum clot firmness did significantly go up when you got the platelets up into this range. Okay, so case 2. The liver and portal vein blood flow. This patient was a 46-year-old male with stable ulcerative colitis on 5-ASA. He had PSC. He was very athletic, but after 6 to 7 years of stability, he started developing hepatic encephalopathy, or HE. He had a previously known spontaneous splenorenal shunt, but no significant varices at endoscopy. His workup, when he started becoming symptomatic, revealed an occlusive main portal vein thrombosis and liver atrophy. And he was fairly encephalopathic. We had him heading towards liver transplant. At that time, we weren't using DOACs. We started him on Coumadin with a target of around 2.5 on a baseline INR of 1.3. Again, this is very problematic in liver patients. We're kind of guessing, but that's what we did. Nowadays, we would not use Coumadin. But you can see here is thrombus in the portal vein, completely occlusive, and his liver was atrophic. And here's his splenorenal shunt. It was quite large. Unfortunately, he did not have gastric varices, though. After 6 months of therapy, re-imaging showed that he had achieved a degree of recanalization of the portal vein. He was still having a hepatic encephalopathy. We measured his portal vein velocity at very slow, 6.9 centimeters per second. Less than 15, and you start running into a higher risk of clot. So we did a test occlusion of the shunt with a balloon, and we showed his portal flow jumped up and his portal vein expanded with the blood flow to 90. So we did a partial occlusion of the shunt. And the way we did that is we put 2 side-by-side stents into the shunt and occluded one of them. So we reduced the flow in the shunt by about 50%. And this is what happened to him over time. Unfortunately, I can't. Let me see if I can move this box. So after 6 months, he had some improvement in some of his liver parameters. And I'll call your attention, most importantly, this is the liver volume. And at 6 months, his liver volume was 873 mLs. After we placed the stent, the 2 stents partially occluding so we did a partial Berto, basically. 21 months later, we re-imaged him, and his liver volume had increased to 1,300. He was no longer symptomatic. We took him out of the transplant clinic, and we've been following him now for 6 or 7 years. And this shows you pictures of the liver before and after restoring good portal blood flow. And you can see it went from a small shrunken liver to a fairly generous size, normal looking liver. And this shows you here one of the stents that we occluded, the other stent was left open. So the takeaway messages with this are that, let me move this box over again. Restoring portal blood flow can result in clinical recovery. The portal blood appears to be trophic for the liver. And also the spontaneous splenorenal shunts that we run into appear to be a significant risk factor for portal vein thrombosis. And the case also demonstrated a careful collaboration between hepatology and IR can really produce some remarkable results, as I think we all know. Okay, so case 3. This is a 75-year-old female with NASH cirrhosis, complicated by ascites. She had a bout of bacterial peritonitis. She had had esophageal variceal bleeding, was status post-serial banding, and she also had problems with encephalopathy. She developed a partial right portal vein thrombus in 2015, and then was noted to have extension into the SMV and the splenic vein in 2017. At that time, she was having increasing ascites, although her varices remained under control, and her hepatic encephalopathy was stable on therapy. With the extension, it was decided to, because she also had symptoms, it was decided to anticoagulate her. So we started apixaban, 5 milligrams BID. Well, 3 months later, she had a bout of encephalopathy and a ground level fall and developed, let me move this box, a subarachnoid hemorrhage. She was transferred to UVA from local hospital. We didn't, by the time she got to us, we didn't add any procoagulant factors because the apixaban would have been worn off by then. Her mental status slowly improved. Her thrombus a year later has remained stable, and she's relatively stable. She did recover from this and wasn't left with neurological deficit. So, you know, what I wanted to illustrate here was the risk benefit of anticoagulating, and things to remember if you're going to consider anticoagulation in portal vein thrombosis. You want to consider the extent of the thrombus and is there progression, the presence or absence of symptoms. About 50% have symptoms. Ascites has been the biggest problem in my experience. They may have pain, they may have variceal bleeding. You need to consider their transplant status, and I'll show you a little bit of data on that in just a minute from Inglesby. If they're a transplant candidate, it would lean you towards treating to try to make the surgery less technically difficult. Consider their fall risk, their bleeding risk. We usually will do an EGD, but it's important to remember there's spontaneous resolution of a partial portal vein thrombus in 30 to 50%. And also, if they've already developed a cavernoma, you're very unlikely to open that up, even with therapeutic anticoagulation. Now, I've always wondered why they get worsening ascites, because you've diminished portal blood flow when you have a thrombus. You would think there would be less driving force on developing ascites. But it's recently occurred to me that probably the reason we see this is that the hepatic artery is still pumping blood in, even more than normal. But now you've lost the hepatofugal outflow through the portal vein. So no longer can that blood egress from the liver through the portal vein. Now it goes out of the liver as ascites or a pleural effusion. I don't have data for this, but I think that that's what's happening. Well, if we anticoagulate, how effective is it? This is a meta-analysis from Violi's group in Rome. They combined 8 trials. They used either low molecular weight heparin or Coumadin with 353 subjects in the study. It was retrospective, but there was significantly more repermeation of the portal vein in the treated patients, not surprisingly. But more importantly, there was actually less bleeding in the treated patients, presumably by restoring portal blood flow and lowering portal pressure by that mechanism. If you're into scores, there is a risk score for using anticoagulants. It's not been studied carefully in cirrhosis patients, but these are the factors that go into the HAS-blood score. I actually don't use this. I make a clinical decision, but some of the residents and fellows like to calculate scores, and they look at risks like hypertension, renal disease, liver disease, stroke history, et cetera. I think cirrhosis, though, the main factor is that you've got to view cirrhosis as an acquired protein C deficiency, coupled with often with slow flow in the portal vein. So I touched on the impact of portal vein thrombosis on transplant. There was a nice study from Inglesby. I think this is one of the best ones that looked at this question. They, like others, noted that there's variable reports on the effect of waitlist mortality, so it doesn't clearly increase a person's risk of dying pre-transplant. However, it increases the complexity of the transplant. So the survival benefit of undergoing liver transplant only comes at a higher MELD. And I think this really reflects the post-op impact on survival and outcomes. So again, if someone's going for a liver transplant, it's a factor that you would weigh in favor of anticoagulating if they have portal vein thrombosis. Now, rarely in portal vein thrombosis and cirrhosis, you can get mesenteric ischemia. This is much less common than you might think, but it does happen. It just happened to us 2 weeks ago. This was a 56-year-old man with stable hepatitis C cirrhosis, presented with severe abdominal pain, and you can see the thrombus here and extending into the portal here and here. But this was occlusive. His lactate went to 29. And he had to undergo bowel resection for ischemic bowel. And you can see this thing that looks like a caterpillar kind of is the section of bowel with necrosis here that had to be removed. And post-op, he had an immediate TIPS and thrombectomy, and then he was started on heparin. But when we tested by the ROTEM to see the effect of the heparin, because the anti-10A test in heparin therapy and cirrhosis is not, I find it not to be reliable. But we showed that he was heparin resistant, and his antithrombin level, which is made in the liver and isn't the heparin cofactor, was quite low. So we switched him to bivalirudin. He's still in the ICU, but he appears to be fairly stable at this time, and he's now been taken off the bivalirudin after about 10 days of the course. And the reason we did is because he had an open TIPS, and so we felt comfortable in taking that off. What about prophylactic anticoagulation and cirrhosis to prevent portal vein thrombosis? This is a prospective, randomized, controlled, but not blinded study from Eric Avila. It's a little bit old now, but it was very provocative. It was fairly small, and this really needs to be repeated in a blinded and larger controlled trial. But what they showed was, indeed, they decreased portal vein thrombosis, as you would guess, but more importantly, they decreased episodes of decompensation in controls versus treated patients. And they improved survival. Now, the patients were treated for 2 years, but the benefit lasted into a 3rd year. So, you know, something like this, if this is confirmed, can really influence the need for liver transplant and might improve our wait list issues. We recently got approval to study edoxaban. COVID kind of derailed our plans for, at least for the time being, but we're hoping to come back to that once things are stabilized and have a larger prospective study. We think the benefit here may be mediated by prevention of small microthrombi in the liver and prevention of organ atrophy. Well, case 4 is a 64-year-old male with he had a history of stage 4B mantle cell lymphoma, which had been successfully treated. Post-treatment, he developed cirrhosis with ascites, and then was found to have a positive hepatitis E test. We treated that with fairly low-dose ribavirin, got rid of it. His ascites resolved. He clinically improved with diuretic therapy, but 2 years later developed this portal vein thrombosis. He had some extension. We elected to treat him with apixaban. I would have continued this, but the hematologist wanted to treat for 3 months. And so the reason they were concerned especially was because he had chronic thrombocytopenia, and consistently in the 40,000 range. Now, the dogma in hematology is that these patients are at very high risk for bleeding in non-cirrhotic patients. So he was stopped on therapy at 3 months and subsequently developed symptoms and again had increased thrombus. So we resumed apixaban at a little bit lower dose, and now several years later, he's fairly stable. He does still have some residual mural clot. He's only had low risk varices. We did undertake prophylactic banding early in the course with him. But I think this illustrates, and this is another similar patient where the hematologist wanted to stop therapy because of low platelets. In this case, the patient was on enoxaparin. We did a ROTEM and demonstrated that his clotting pathways were actually fairly intact, even on therapy. And so we continued low molecular weight heparin. He's done fairly well. And so I think my point with this is that the traditional hematologic tenet of stopping anticoagulation if the platelets go under 50,000 probably don't apply to cirrhosis patients because of the hypercoagulable state. And that mainly is due to the acquired protein C deficiency, in addition to high endothelial-derived factor VIII and endothelial-derived von Willebrand factor. They also have slow portal vein flow and endothelial injury related to the liver disease. And of course, these three are Virchow's triad. If you throw in a splenorenal shunt, you probably even more slow portal vein flow. What role do the genetic thrombophilic factors play? Maybe some role, and it's seen in about 10 to 20%. It's unclear if the acquired changes of cirrhosis overwhelm this. I think it probably does. So we don't routinely check for prothrombin mutation or factor V Leiden in portal vein thrombosis, unless maybe it has some question to do with how long will you treat if someone wants to stop therapy. So maybe it has a role, but not very much. And again, this shows you the protein C deficiency. This is the ratio of thrombin production with or without thrombomodulin in child 2A, B, and C. And you can see there's a stepwise increase in thrombin production. So the cirrhosis patients are relatively hypercoagulable, even compared to congenital or genetic protein C deficiency. So last case, this is a 56-year-old male undergoing a transplant evaluation. He had prophylactic dental extractions and developed persistent bleeding. Platelets were around 60,000. Fibrinogen was low normal pre-procedure. The bleeding would not stop, and he was admitted and treated with aminocaproic Amicar to stop fibrinolysis. We did get control of bleeding, but by this time he was really decompensating, and he went into acute or chronic liver failure and passed away. The case illustrates, premature clot dissolution or failure of clot or hyperfibrinolysis, also called AICF, accelerated intravascular coagulation and fibrinolysis. It remains controversial with discrepancy between clinical appearance and laboratory testing. Just to review the fibrinolytic system, it's a normal system involving TPA, which activates plasminogen, plasmin. Many of the factors are endothelial derived, some are liver derived, and you have both factors that break down clot and then factors that slow down plasmin, like plasmin activator inhibitor, alpha-2 antiplasmin. And so this system normally is in balance, but it appears that it can go out of balance in liver patients. Indeed, it's one of the oldest hematologic conditions associated with liver disease, going back to this paper published in 1914 from Dr. Goodpasture. So it's been around a long time. It's very difficult to measure, though. This is a study by Dick Ridgen in the Netherlands, showing diminishing clot lysis time in Child-Pugh, progressively worse Child-Pugh cases, and an increased, what he called the global fibrinolytic capacity. And he attributed these changes to differences in alpha-2 antiplasmin, PIA1, thrombin activatable fibrinolysis inhibitor, or TAFI, and especially with TPA activity. But I think this remains a clinical diagnosis. It's characterized by diffuse mucosal and puncture wound bleeding, late post-procedural bleeding, so they form a clot, the clot prematurely deteriorates and they start bleeding. It's not so much driven by portal pressure, which is much more common. It resembles DAC, except factor VIII is generally elevated. It may respond to Amicar or tranexamic acid, but I think it's very difficult to confirm it by clotting tests, even using viscoelastic whole blood tests, like TEG or ROTEM. These tests use whole blood that's recalcified. There's a newest one is called sonorrheometry, or SR, uses ultrasound to examine the clot thickness. And these have mostly been used to show intact hemostatic pathways. Whenever we've tried to look at premature clot lysis or hyperfibrinolysis, we have not found it, even when the patient is responding to Amicar and has a clinical syndrome. Well, not very long ago, I discovered the group who's reported on this the most is out of Royal Free Hospital, Andrew Burroughs' group. And they consistently could demonstrate hyperfibrinolysis. I later learned that they run the test with what they call a native tag in the liver patients. They don't add any activators, and they run the test for a full hour. Unlike in our place, we add activators and we run the test for 20 minutes. So I think this is a case where nuances matter, and little differences in how these tests are run make differences in what the results are. I've not tested this, but I think that's the explanation. Well, to close, there's some final things to mention, some changes in fibrinogen known as dysfibrinogenemia. What dysfibrinogen is, it's a fibrinogen with increased oxidative injury, evident by increased carbonyl content. In this study, Ton Leisman assessed clot kinetics by the thrombin generation assay. What he found kind of is puzzling. There was similar fibrin density and thickness, but decreased permeability of the clot, which inversely related to clot lysis. So what Ton is saying in this paper is that these clots should be more resistant to lysis. And I can't explain it, but to me, there's a real disconnect with clinical experience and results like this. And this isn't the only paper that's shown something like this. So I don't understand it. So that's the reason I would emphasize that you have to make a clinical diagnosis of hyperfibrinolysis and then treat it if you believe that's what it is. So to summarize, we've seen variceal banding with an elevated INR or low platelets is generally okay. We've seen the benefits of restoring portal blood flow and portal vein thrombosis, and we've seen the risk of undertaking anticoagulation in portal vein thrombosis with the lady who had a stroke. We've talked about the hypercoagulability of cirrhosis, which you really need to see as an acquired protein C deficiency. And once somebody's had it, they're going to recur. So a finite treatment period is probably not realistic, and you probably need to treat them for extended duration. So I want to remind everybody, COVID kind of derailed this project, or at least slowed it. We're trying to reopen it now. It's being run by Nick and Tagliata. I know Alberto is part of this. It's an international consortium to look at procedure-related bleeding risk in cirrhosis called Prophylactic. And if any of you are not in it and you want to be, then let me know, and I'll get you in touch with Nick and Tagliata, my colleague here. Finally, last slide. You can't have a talk nowadays without throwing something in about COVID. It's kind of taken over the world. But we did, I'm reviewing now a manuscript demonstrating intrahepatic microthrombi in a small series, 7 patients with severe COVID. We also had a recent case at UVA that we think was caused by biliary ischemia in a patient who had resolved COVID in her lungs and presented with a severe cholestatic hepatitis. We found in her common duct was obstructed by what appeared to be necrotic material, and she had very friable, fragile biliary tree. And we think that this most likely is COVID-related ischemic injury of the liver. Unfortunately, she is now in comfort care, and this did not get better, even despite putting a stent in and relieving the obstruction. For those of you who hadn't visited Charlottesville, this is UVA. This is the undergraduate campus. This building here is called the Rotunda, and this is looking west towards what are called the Blue Ridge Mountains, which are only about 20 minutes from here. This is the medical school, rebuilt about 10 years ago now, still referred to as the new medical school. And this is the main hospital. There's now another wing back here, and 2 of those floors are dedicated to COVID patients, although fortunately our numbers have been here going down, thank goodness. Not so true in other parts of the US. Just to close with a funny slide, for those of you who sort of view hepatology as claiming everything, which I guess we do, I just wanted to show you some better names for some of the organs you're familiar with, like the primary hepatic peripheral ganglion, the hepatoaerators, the hepatopump, the 2 hepatofilters, the hepatolocomotors, and of course what we talked about today, the hepatosealant system. So I think I won't go into that. Well, this is if you can't divorce your interventionalist from giving plasma, we are selling the infusilator, which drips brown fluid that circulates under the mattress into a collection bag and then back to this bag. So it makes the operator very comfortable to see this. Just kidding, it's a joke. So, well, thank you for everyone's attention.
Thank you very much, Steve. And Alberto, I asked Leila, and I think we have time to present your case. Bruno will present. It's a very similar from one of the cases that Steve presented.
Mário,
Diga.
Tenho 3 perguntas da plateia para discutir rapidamente antes do caso. Eu selecionei, a maior parte eu já respondi. Steve?
Yes.
We have 3 questions from the audience. I will say both in Portuguese and English.
Okay.
Primeira pergunta, doutora Maria Chiara. Anticoagulantes diretos na trombose portal. Primeira pergunta. When do you use the direct antithrombin agent for treatment of portal thrombosis? Do you believe they are safe?
Yeah, you're talking about, I guess, dabigatran.
Yes, apixaban, dabigatran. Yeah.
Yeah. Well, those I think are preferred nowadays. We've published Nick Intagliata, Pat Northup, and Nirol. You know, there's several publications, especially Nick, that show the relative safety. I'm not real convinced. I think the most effective agent is enoxaparin, given subcutaneously, but it's hard to do because the patient has to take shots. I think Coumadin is the most difficult to use because everybody knows how terrible Coumadin is and so many interactions. Dabigatran, or that's a factor prothrombin inhibitor, and the factor 10A inhibitors, apixaban, rivaroxaban, those I think are preferable, and they are effective. I think they're safe. Any of them can have problems like we saw with the lady who fell. But I think that, yeah, to answer the question, yes, would recommend those agents.
Okay. And also from Maria Chiara, when the baseline INR level is enlarged, I mean more than 2, do you still use Coumadin or prefer another agent? If you do, what's your target level for anticoagulation in such cases?
Well, in the old days, we would use Coumadin and we would target around 2.5. I mean, it really, you've seen from the information, the INR and cirrhosis is a poor target. And so nowadays, I would only use Coumadin if for some reason that was the only choice. I think we have one patient who we are using Coumadin because they can't afford the 10A inhibitors.
Okay.
But outside of that, I would much prefer either the 10A inhibitors or the prothrombin inhibitor or enoxaparin. In those, you don't really target the INR, as you know.
And also, we know that our difference between anti-10A agent related to inhibition of the thrombin production, and apixaban and dabigatran seem more effective than when compared to others. So, in your practice, do you choose apixaban because you use it twice a day, or do you use Xarelto or other agents? Because I personally use apixaban because it's twice a day. We may use reduced dose, and also has an interesting action on thrombin generation when compared to the first generation agents. So I would like to see what you do think when choosing wisely these agents.
Well, we usually use apixaban, and that was because really our hematologists preferred apixaban. I don't have a lot of experience with rivaroxaban. We've got a few patients on dabigatran. That's the prothrombin inhibitor. It's said to have a lot of GI side effects. I've not seen that, and I think we have one patient on it right now that I'm aware And that patient's done pretty well. I can't remember why we used dibigatran and not apixaban, but there was some reason that we did that, but I'm sorry, I can't remember now. But most of the time we go with apixaban. That's probably because of a bias from our group. That's what we started with, and that's just what we stayed.
But we, according to a paper from Tom Leisman, and these agents reduce more thrombin generation when compared to first generation agent as the rivaroxaban. Rivaroxaban seems the worst because it reduced by 10 or 12% as compared to 50% of these agents.
I think I'm familiar with the paper you're talking about. Yeah. Yeah.
And the last question from Mario Hayes. When do you think it's mandatory to use ROTEM or in thromboelastography? Makes difference or not? Is really necessary?
I think it's maybe useful. You know, ROTEM has the multiple channels, so you can pick different subtypes of ROTEM. We no longer have a tag, so we really don't have a choice. I think any of those are useful mainly to, if somebody is worried and they're trying to give prophylactic factors, you can often use any of the viscoelastic tests to show that the hemostatic pathways are working fine and maybe even working extra, and avoid blood products. I think you guys, there was some group in Brazil, I think you may have been part of it, recently demonstrated this again. And so diminishing blood product use, unnecessary prophylactic measures is the strongest thing. Use of ROTEM or TAG. Recently, ROTEM has a channel called the HepTIM, which neutralizes heparin. And so we use that just recently to demonstrate heparin resistance in the patient I mentioned, because when we measured the XTIM and the HepTIM, there was no difference in the values really. So that means the heparin wasn't having an effect. And that's probably because we measured his antithrombin. Antithrombin, recall, is heparin cofactor. You have to have antithrombin for heparin to work. The liver makes antithrombin, and in advanced liver disease, the value goes down. This influences not only the efficacy of heparin, but it also influences the anti-10A assay, which is how we monitor heparin therapy now. So you really got to be careful. It's helpful to measure the antithrombin level, and maybe we haven't studied it in great detail, but it would be an interesting project to, in heparin-treated liver patients, to measure HepTIM compared to XTIM. That's how we used it.
Okay.
Alberto, eu gostaria de fazer uma pergunta para Steve também.
Mário?
Regarding your case number 2 was very interesting. We know that these microthrombs inside the liver can lead to progression of liver fibrosis and atrophy of the liver. Can we learn from your case that this is a reversible situation that we can reverse with anticoagulation?
I think that's probably true if you restore portal blood flow. Now, I think we got lucky because I think the guy didn't have terrible fibrosis. When we took down partially took down the shunt, he had enough compliance in his liver that the blood flowed through it. I'm sure many of you have had the experience of doing a Berto in someone where you get rid of the shunt and they totally decompensate with ascites and pleural effusions. And I don't know that we know how to predict who has that bad outcome versus who has a better outcome. You know, maybe something like MR elastography or FibroScan or something like that could predict that. But I think anticoagulation will have a role to prevent organ atrophy, and trying to improve portal blood flow is really important in these patients.
Steve, we have still 2 questions before the case. I'm sorry, because this is a very interesting subject. One question is from Luis Edmundo. Do you use this direct antithrombin agent for Budd-Chiari syndrome 2, for hepatic veins, or only for portal vein thrombosis?
I've never used one in Budd-Chiari. We don't get many Budd-Chiaris. I don't see why it wouldn't be helpful. You know, the best therapy that I've seen for Budd-Chiari, though, has been to place a TIPS followed by coagulation. Or, you know, if they're in liver failure, they have a transplant. But so I don't see why it wouldn't work, but may need to be coupled with recanalization of the hepatic vein. Okay.
Leila, the last question is from Liliana from Brasilia. The question, if a patient has a portal cavernoma and with a free patent mesenteric vein, do you use anticoagulation as low heparin and keep this patient on anticoagulation until liver transplantation, or not?
Well, once they form a cavernoma, you're not going to open it up with anticoagulants. So you may be taking risk that doesn't have benefit. On the other hand, if they're having pain and you think that they may be extending thrombus in some of those small channels, I have treated in that setting before, even when they weren't a transplant candidate. And I don't know if I was doing the patient any big favors or not. They didn't have big complications from it.
Yeah. Well, for the question, that's all. Steve, thank you very much for this very nice presentation. And if you have time, we wish to hear from you on the case that will be presented by Mário and Dr. Bruna. Mário, please, the case.
Okay.
You speak in Portuguese a little bit now. You have the slides in English.
Yeah. Bruna will present the slides in English, and Bruna will present the case in Portuguese.
Bom dia, meu nome é Bruna, eu sou médica preceptora da divisão de gastroenterologia e patologia do Hospital das Clínicas da USP, e agradeço ao Dr. Alberto por convidar para apresentar esse caso. I want to ask to Professor Caldwell to speak in Portuguese as I was requested, but if any doubt about the case, we can try to solve, okay? Paciente masculino de 51 anos com diagnóstico de cirrose prévio, de etiologia viral, vírus C, paciente child de B9, mel de 19, com complicações prévias de cirrose, da cirrose em ascite, e um sangramento, uma hemorragia digestiva alta por varizes esofágicas, previamente, 6 meses prévio. Esse paciente foi admitido no hospital devido a um abscesso dentário e submetido a um procedimento de extração dentária. E após esse procedimento, intercorreu com sangramento local, um sangramento em babação, que apesar das medidas locais de tentativa de controle do sangramento, não foi possível esse controle do sangramento, o paciente continuou sangrando. Foram solicitados alguns exames complementares, a gente pode ver aqui hemoglobina de 9,3, creatinina 1,1, calciônico de 5, INR de 2, 60 mil plaquetas, um fator 5 de 55% e um fibrinogênio de 179 miligramas por decilitro. Foi optado por fazer um tromboelastograma, que nós podemos ver aqui, né, pela foto, só lembrando os resultados, só lembrando que o R é o tempo do início do teste até a formação do coágulo, o ângulo alfa, né, também, a MA, amplitude máxima. E, então, as questões para que os professores possam discutir com a gente seria qual seria a interpretação desse tromboelastograma desse paciente, qual seria a provável causa desse sangramento e qual o tratamento proposto para esse paciente. Vou deixar aqui um trombo. Aí fiquem à vontade, professores.
Hi, Steve. We have three questions. We may split the task. I could comment the thrombo, Mário the cause, and you the possible treatment. Do you agree?
Yeah, I can't quite see the numbers at the bottom because but I you kindly sent this to me and I remember.
Liz's time, Bruna, what the Liz's time is 23%. Liz's time 23%, and the range is 0 from 8. Means is 3 times the normal range.
Yeah. So I think the case is like the one that I presented as well, where you're getting premature clot lysis.
Yeah.
And, you know, clot lysis, it's physiologic in every body cavity, you know, from peritoneum to mouth to biliary tree to bladder. Every body cavity can dissolve a clot. And it's important because obviously there's places where you don't want clot to stay. In the case of dental extractions and mouth, the oral cavity, why it goes off excessively in some patients and not in others, I don't know. I think infection probably has something to do with it, but it's definitely an imbalance in the fibrinolytic system. And treatment is pretty good, really. You can either use, if it's not much, you can soak a gauze pad with Amicar and then have the patient just bite on it for a while. Otherwise, if it's really brisk bleeding or just, you know, continuous and not amenable to topical therapy, then I would give an infusion of Amicar. And we would usually do a loading dose and then hourly dosing for 8 hours. We've used it longer in some patients. The nice thing about the antifibrinolytic agents is that they aren't so procoagulant, unlike giving recombinant activated factor 7 or PCC, prothrombin complex concentrate. Those make you hypercoagulable and can precipitate clots in bad places. Amicar and tranexamic acid don't make the patient hypercoagulable unless there is already a clot somewhere. So if they have a DVT, and this isn't uncommon for these cirrhosis patients to be simultaneously clotting and bleeding. But if they have a DVT or deep venous thrombosis in the leg or something like that, I'm a little concerned about using Amicar, but we've used it in that setting and we didn't have a big problem.
Eu vou falar em português, se tiver em português. The audience, the many medical students. Esse é o exame, é um tromboelastograma, é um exame global de coagulação, em que avaliamos os procoagulantes, os anticoagulantes naturais e o tempo de destruição do coágulo. Então, observem que, apesar desse paciente apresentar um INR alargado anormal, o parâmetro R, que corresponderia ao INR, o tempo de protrombina, está normal, mostrando que o INR não reflete realmente a coagulação do paciente com cirrose. E o que chama a atenção é o tempo de lyse, o tempo em que o coágulo se desfaz, que está 3 vezes acima do normal. Então, o diagnóstico desse caso é uma hiperfibrinólise. E a melhor opção para esse paciente é o tratamento com drogas antifibrinolíticas, como o ácido tranexâmico. Então, esse é um exemplo de uma situação que foi resolvida com o trombo. Se tivéssemos dado plasma ou fatores pró-coagulantes, pensando no INR, teríamos colocado o paciente em risco de ficar pró-coagulável e de trombose. Steve, this is a native TID. We didn't use any activator. You'll see how
Yes.
it helps.
Yes, that's fantastic. I think you're doing it the way I wish our people would do it, but our ROTEM was put in mainly for trauma or certain patients, and we have not successfully convinced them to run the cirrhosis patients differently.
Okay. Mário?
Esse caso, Alberto, foi muito parecido com o caso número 5 que o Steve apresentou, do paciente que fez hiperfibrinólise. Essa curva você tem ensinado bastante para a gente em termos de tromboelastografia, que é típica do paciente que formou normalmente o seu coágulo, mas esse coágulo não tem estabilidade e o paciente tem hiperfibrinólise. Como o Steve já mencionou para a gente, que comum desses casos de sangramento de mucosa, não se sabe exatamente o porquê esses pacientes fazem esse quadro de hiperfibrinólise. Agora, minha pergunta para você, Alberto, e para o Steve, a gente pode prever isso de alguma forma, porque nós sabemos que o INR não é bom para isso. Esse paciente tinha um número de plaquetas aceitável para um procedimento e também o fibrinogênio de 179, quer dizer, Steve, can you precede in those cases this patient with a normal, well, the INR is not the perfect exam to for you to guess if your patient are having a problem. This patient has kind of a number of platelets that is okay to do a procedure.
Right.
And how can we precede this situation of hyperfibrinolysis like this patient? Is there a way that we can predict that?
Is a predictable complication?
I think if the patient is, there may be some parameters to predict bleeding, but there's not, you know, we mentioned platelet count and fibrinogen, and those even get critiqued a lot. And in this case is a good example. So I don't know how to better predict. And what we usually recommend is to make sure, try to control infection, control renal function, because those are two treatable conditions that contribute to bleeding. Try to control their volume so that they're not excessive intravascular volume. And then be prepared with a good therapeutic plan should they have bleeding. This is kind of how I recommend approaching these patients. You optimize the platelets. This patient didn't need that. You optimize the fibrinogen. He didn't need that either. But then you're ready if there is a bleeding complication and clinically diagnosed with hyperfibrinolysis, then you treat them.
Okay.
I think that's the best we can do right now.
Yeah. Okay. Thank you, Steve. For time constraint, I believe we have to stop. I wish to thank you again, Steve, for accepting kindly our invitation. It was a real pleasure to see you again. And we have an audience of almost 8,000 people in Texas for a lunch meeting. Thank you so much. And Leila, please.
Okay, Steve, once again, thank you very much indeed to help you guys. Excellent talks as usually. And now I'm going to speak Portuguese to save. Pessoal, eu queria agradecer a todos, ao Mário, ao Flair, pela essa participação em conjunta. Queria dizer a vocês que nós chegamos a quase 1.000 pessoas assistindo, uma inscrição de 1.780 pessoas. Então, acho que é um número extremamente significativo. Gostaria de lembrar que esse QR Code que foi colocado aí é porque nós estamos na campanha da solidariedade, né? O Instituto do Fígado já fez várias campanhas solidárias nesse momento tão difícil que nós estamos vivendo. Então, isso é uma forma de quem tiver apenas o desejo de contribuir para que nós pudéssemos manter essa solidariedade nesse momento do Covid-19. E, para finalizar, eu gostaria muito de agradecer a comissão que me ajudou e vai continuar me ajudando até o final, né, até a última palestra no dia 12 de agosto, a Luciano Beltrão Pereira, a Deise Arocha, a Lani, que vem há mais de 15 anos organizando o Hepato Pernambuco junto, e a AVT Produções, que nos disponibilizou essa novidade para nós, que é trabalhar através da webinar. Então, espero todos vocês amanhã, né, às 1h15, para nós falarmos sobre NASH, com o professor Vlad Hatzu e o professor Pierre Bedossa, e com a participação da professora Cláudia Oliveira e do professor Venâncio, juntos amanhã, mais uma vez, dando continuidade ao Hepato Pernambuco 2020. Tá? Então, com isso, eu acho que nós podemos finalizar e dizer que o certificado está online, no link online, para quem quiser ter o seu certificado nessa palestra. Muito obrigado a vocês e até amanhã.
Obrigado, Leila.
Obrigado.
Obrigado a todos.
Obrigado.
Bye, bye,
Ciao,
Steve.
Steve. Thank you so much. Bye-bye.
Thank you all.